Welcome to the Sleep Innovators podcast. Conversations with leaders in sleep medicine.
Hi, it's Michael DiDomenico. Today, we have a special guest, Dr. William Noah. Dr. Noah is the medical director of the Sleep Centers of Middle Tennessee, which has grown into one of the largest sleep medicine practices in the U.S. He is also the chairman of the Middle Tennessee State University Research Consortium. Dr. Noah is also the CEO of SleepRes. And in June 2022, he introduced the VCOM, a revolutionary new device to improve PAP adherence. Dr. Noah, welcome.
Well, thank you, Michael. It's great being here with you today.
So just last week, an article came out in Sleep Review magazine, an excellent article about how PAP devices have been engineered backwards since their inception. You contributed this article as well. Your findings that epap is really where the therapy lies, where the action is happening for patients to reduce their hypopneas and apneas. And IPAP isn't really what's driving the therapy. How did you arrive at that?
Well, excellent question. And the word backwards was used, I think, by the journalist, not me. It's not backwards therapy because obviously 50% of the patients are tolerating it long term and doing well and getting benefits. We may be a little bit twisted in our understanding historically, and I think that's what I'm bringing to light now. And it goes back to when CPAP first came out with Colin Sullivan in 1981. Actually, inspiratory pressure was lower than expiratory pressure because machine couldn't maintain the pressure as you breathed in, at least not as well as it's manifested today. But it was in 1990 when Sanders and Kern at Respironics introduced what we call BiPAP, where you separated now inspiratory pressure and expiratory pressure. And when they did their first sort of trial, they did inspiratory pressure higher than expiratory pressure, and no one ever tested expiratory pressure higher than inspiratory pressure. How they came to that understanding is probably threefold. Number one is they found out that they could, by adding or increasing the inspiratory pressure, they could reduce expiratory pressure, which they thought might be more comfortable and lead to greater adherence, maybe prevent some adverse effects. That has not panned out over 30 years, except in a few patients with certain situations. They also, had the understanding that hypopneas or partial obstructions and snoring occur during inspiration principally. And the forces that lead to airway closure or obstruction during respiratory cycle will tend to be higher during the inspiratory phase possibly. So I think that led them to making IPAP higher. Also the fact that they started using BiPAPs for ventilators or home ventilation, and obviously you need IPAP much higher than EPAP to decrease the work of breathing in people with poor lung mechanics. And I think they thought that would also translate to patients with sleep apnea, and that's probably not true as well. So that's kind of what got us off track, and it really wasn't ever questioned.
Dr. Noah, what's the evidence that convinced you that IPAP less than EPAP was the way to go?
So it goes back to 83, that, the Mahadevia study where they just use EPAP alone and they were able to treat both expiratory events, apneas, and inspiratory events, hypopneas and snoring. And then you look at it's end expiration where the airway needs to be stabilized. And IPAP alone does not affect that at all. IPAP doesn't affect functional residual capacity, which obviously EPAP does. So those were the initial things in literature. Then looking as the resistance increases and the cross-sectional area decreases in the expiratory phase as you reach the end of the expiratory phase. So all these factors were sitting here in my head that basically, Mahadevi's group treated obstructive sleep apnea without any IPAP. And then you look at the nasal EPAP devices that are on the market that are resistors basically in the nares, and they only provide expiratory pressure. They only provide end expiratory pressure. And yet they're able to treat inspiratory events like hypopneas and snoring. So all that really made me think maybe we have it backwards. But really the final straw was when I actually released the VCOM and could actually put it on people. And what we found, of course, is we're dropping IPAP on all these patients, but we're not affecting therapy. And it's more comfortable to them.
So there was no way to lower IPAP versus EPAP in the machines that were on the market. So you were kind of stuck there. So you had to create something on your own, which is now VCOM. How did you come to figure out how to make that actual device?
Well, that's a good question. It took a lot of thought, a lot of sort of study to sort of figure out to take advantage of the physics. And so the flow to try to be generally simple about this, the flow in the CPAP circuit is turbulent. And turbulent flow, the pressure drop is by the square of the flow. Laminar flow, it's linear. So taking advantage, that's the shape of the pressure flow curves, a parabola. At very low flow, you have no pressure drop or very little. And then at high flow, you have great pressure drop. And so by putting the VCOM, between the machine and the exhaust port in the mask, well, then during inspiration, you have high flow going across there. All right. So you can have big pressure drop. But on expiration, you don't have flow, at least not much flow going through the circuit. The patient's exhaling, so there's no inspiratory flow, and much of the exhaust flow is coming from the patient. So when you have a little bit of flow, you have a little bit of pressure drop. So it's kind of a little trick taking advantage of the physics in order to be able to test this theory of IPAP, less than EPAP, and be able to put it on large numbers of patients and really get some good data. It was simpler just to go ahead and manufacture it and get FDA registration and be, able to put it on whoever. So we introduced it to APSS, and since there, I guess several thousand patients have already got a chance to experience it.
Yeah, your booth was mobbed at APSS. And I think it's important to point out that this isn't some quackery regarding the engineering of CPAP. Many of the original engineers have come out and said that they agree with you, and also even Jerry McGinnis, who founded Respironics.
Yeah, that's been a really great part of this experience. During the last 8 to 9 months of this is getting these relationships with these pioneers. Jerry McGinnis and Gene Scarberry, and of course, we have these phone calls where the Jerry and Gene, and of course Bernie Heat, who was with them for 30 years at Philips Respironics as well. And we talk through theory and, how we're going to do this, how we're going to put this into the machine, how we're going to do the algorithms. And these guys have been wonderful. I mean, they've taught me so much, because remember, I'm a physician. I had to learn the physics and the engineering kind of after I created it. But that's been a real blessing.
Dr. Noah, how did you get these industry pioneers to agree with you?
Well, it really wasn't hard. When I presented the evidence that I had, it's really just math, and the math, the math makes sense. They grabbed it immediately. I won't say immediately. Everyone has their traditions. This IPAP higher and EPAP. They held on to a long time, but it took really very little time. Kingman Stroh was really interesting because, when he grabbed it, he took it to another level. He goes, yeah, having lower IPAP's more natural because people are used to, dropping the pressure when they breathe in. And I thought, wow, that's interesting. That may be partly why it's more comfortable. But at the end of the day, what really convinced them, just like everyone else, is when they tried it, when they experienced it themselves and they could feel the comfort. Because think of it this way, if the machines were engineered optimally now, then the VCOM wouldn't feel so much better. You'd already have that feel on the machine. So obviously there's a problem.
And you're not making any therapeutic claims about this device. This is strictly a comfort device.
No, those may be coming, likely will be coming, but not now. We're still playing, but right now it's just comfort. And so, when you talk about comfort, it's sort of an ethical thing. So do you need a randomized trial for comfort? But what's sufficient evidence to use the device? Well, for me, Mr. Jones here is trying to wear CPAP of 12, and it's uncomfortable. I give him CPAP of 12 with a VCOM, and it's much more comfortable, and he believes he's going to be more likely to wear it. That's the evidence I need. I'm done. Because you see, when you have a difficult therapy, like CPAP is, it's hard to get used to, and you have something that provides comfort for that, an intervention that provides comfort for a difficult therapy. It doesn't adversely affect therapy, and it has minimal cost. Aren't we ethically sort of obligated to offer it to everyone? The problem with BiPAP was it cost $3,000.
Yeah.
So
expensive.
I mean, now if someone felt more comfortable with it and that comfort experience was worth $3,000 out of their pocket, okay, that's their decision.
And since it's a comfort device, a prescription isn't needed.
No. You have to have a prescription for CPAP. You have to be on CPAP. Its only indication is with PAP therapy. So PAP therapy has to have a prescription. So therefore, it's covered as an accessory under that, just like a chin strap.
So with all this learning you've done, the physics and everything else, what have you learned about masks, especially paired with other machines that may not be of the same manufacturer?
That's a very good question. So it's so funny. A couple people had questioned about, well, the VCOM may be dropping inspiratory pressure, so it may affect therapy. And I'm like, no, it doesn't. We already have all that data. But at the same time, if you use a Philips mask with a ResMed machine, you just dropped inspiratory pressure because they have more resistance in them. Use the Brevita from Fisher-Paykel, you just dropped inspiratory pressure because it's got more resistance in it. Now, what they're not understanding is that same resistance is dropping inspiratory pressure is increasing expiratory pressure as they exhale. So it may be actually improving therapy if expiration is the therapy, not inspiration. So, some of these studies in the literature, in our journals, sometimes I have to sort of laugh because, they'll say, oh, there was a 1 centimeter pressure difference between titrated in the lab and auto titration. And they didn't look at whether they were on expiratory release. They didn't look at what mask they were on. They didn't look at anything else about the circuit, what hose were on. Was the machine set for the right hose? For instance, the machine is set at a 22 millimeter hose and you've got a 15, well, you just drop the pressure on it.
Well, the other thing is that a lot of people are prescribed with flex on their machine or EPR, and this flies in the face of your findings as well. This was meant to help people. They thought it'd be better compliance, but for a relief from expiratory pressure. But what you've learned is that's where the therapy is, and it's actually not helping patients.
No, it's actually hurting. So again, you're increasing IPAP over EPAP because you're dropping the expiratory pressure. The Philips is less because it's flow-based, and so you tend to get the pressure come back at mid-exhalation. But it's no, you're dropping therapy. The great article of that is Journal of Clinical Sleep Medicine in 2016, Zhu et al., ZHU, and they create a bench model with a Starling resistor, and they basically show whether it's EPR from ResMed or C-Flex from Philips, that it's just decreasing therapy. There's an EPAP that each airway needs to stabilize it. And once you get there, you're done. And then if you want to drop mean airway pressure and make it more comfortable, drop the IPAP because it's not as effective.
I think it's really important for everyone watching this video to read the article in Sleep Review. I believe that's their November-December issue of 2022. We'll put a link down below the video for that. Whether you're a respiratory therapist, sleep technologist, sleep physician, just interested in sleep and how CPAPs work and how they've been engineered, it's a great article. So you developed this product out of your desire to help patients, for patients to be more compliant, not to sell product necessarily. What's next?
From a comfort point of view, yes. From a comfort point of view, it's a no-brainer. We put it on everyone because we know it's more comfortable. There's still studies to be done. This finding I have with it decreasing mouth openings and chin straps by 85%. We need to get this first study published. We need to do we need to get other people to do the same investigation. Let's see if this holds up. The issues with Texa, we need to look more into that. It's only 15 patients. Yes, it makes sense, but we need others to try to replicate the same study at their institution. We need to look at long-term adherence. We need to see if it's really going to make a difference. And
Dr. Miller, there's also been some talk that it actually makes the CPAP machine quieter. Patients want to keep it for that reason. Have you found that to be true?
Yes, that's true. Actually, one of the executives from one of the manufacturers is who discovered that. He was down here in my lab last year, and he had already tried it before, but he was here visiting, and we were putting it on someone else. And he goes, "Hey, it makes it quieter." So immediately we got decimeters, the next day, or was it decimeter or decibel meters? And we tested it, and we found it about 15, 20% less decibels. And that's because of the effect it's having. So that's true.
Especially good for bed partners.
Right. In fact, I think of this 80% of long-term users who preferred the feel of the VCOM, I'm not sure all 80% preferred the feel. I think some of those were their bed partners preferred the decreased noise, so that was good. And plus, as you're dropping inspiratory pressure, you're also dropping exhaust flow during inspiration. So that, may decrease a little bit of blowing on them as well. But that's a very good question. Yeah, that was another surprise. I was not expecting, when we did this.
So you've got all these things you find out during the process and of treating patients and just the whole development of it. And this is the first product that you've ever brought to market, right?
Oh, absolutely. Yeah. First anything patent filed was my first patent. Now there's been several since then, but yes.
What was it? Anything like you thought it would be? Did you think it would be faster, harder, easier to bring it to market?
Probably all those are true at one point or another. I think the hardest thing I had to deal with was I had to believe myself. I just didn't believe it for so long. I mean, you remember it was July of 21 that I made the first one, and it took me till January to really believe. I mean, I thought about Texa, and I'd put it on all these friends and colleagues, but I just thought there's something I'm missing. We just couldn't be wrong for 30 years. I just couldn't believe it. But really, it's when I started to interact with these pioneers and the engineers and how quickly they just went right to it. Yeah, you're right. And that's what really gave me the confidence. Plus the fact that, everyone we put it on feels the difference. I mean, it comes down to the point again, this is the line I say, and people are quoting it, is that if the machines were optimally engineered, then it wouldn't be helping. And you have a treatment that only 50% of people will use long term. And so we need every tool we can to try to make it better. And but yes, it was an interesting road. I have learned tremendous about the system and how it works. And of course now, I've designed masks. I've got new technology that I think is going to revolutionize kind of how masks are used, that will be coming to market. We've got the algorithms in the machines, not just about comfort, but some safety issues with machines that we're putting, that we have patents filed. And so it's a lot of fun, Michael. I can tell you this last couple of years has been the most fun, I think, of my whole career.
That's great. So the things you're working on now, you've got new things. You're finding the process easier since you've done it before? Or does it always present new challenges?
Always presents new challenges.
So let's tell people how to get their hands on a VCOM. What's the best way to get that?
Well, right now, the best way is to go to sleepres.com. And there, if you're a healthcare provider, you can order a sample for yourself to learn more about it. If you want to order them wholesale as a supplier of some type, you can order them by the box there at 50. And if you want to send a patient there to get one, they can buy retail directly from that site. Our site will link them immediately to another site where they can purchase one for themselves.
Good. I know you'll be with me March 24th in Philadelphia for the Philadelphia Sleep Conference. We look forward to that. talking more about this and other things. Always interesting, Dr. Noah. Thanks for being here today.
Michael, thank you so much for your time and excellent questions.